Hi, everyone. On today's podcast, we're going to talk with Trish Ware, a registered nurse and host of the Labor Nurse Mama podcast, about tips for advocating for yourself during labor. Hi, everyone, and welcome to today's episode of the Evidence-Based Birth Podcast. I am so excited to talk with our guest today, Trish Ware. Trish founded Labor Nurse Mama using her 16 years of labor and delivery nursing experience because she wanted to change the birth culture one birth at a time. Trish believes that if someone doesn't know their options, you don't have any. Now, Trish is using that same passion and expertise to coach other perinatal experts on how to bring their knowledge online and create unhinged impact. Trish is passionate about her students and members, but she's also dedicated to helping experts build movements that not only educate, but transform lives, empowering them to make a difference on a larger scale. And today, Trish is here to talk with us about how to use your voice during labor, how to speak up and advocate for yourself. Trish, welcome to the Evidence-Based Birth Podcast.
Thank you so much for having me. I'm so excited to be here today.
Yes, it's like amazing having such a powerhouse on the podcast. And I was wondering if you could share your story about becoming a labor and delivery nurse, and then maybe a little bit about how, when you first realized the importance of advocacy.
Yes, I love this. This is such a good topic for me because it's really the reason why Labor Nurse Mama was born. Honestly, it comes to the root of it. So I had my first child when I was very young, had my last one when I was old. But when I had my first child, I come from a very birthy family, everyone breastfeeds, you have your baby. And I went into that birth really thinking that my doctor wanted the best things for me and that they would be in alignment with what I wanted. And I obeyed everything he said. He said, take a Lamaze class. I took a Lamaze class. He told me, if your water breaks, come right in. If you go into labor, come right in. More than likely, you'll have to have an episiotomy. Now, my son is older. So, back then we didn't question that at all. I had one, even though looking back, I had a very short first birth and I had every intervention known to man. But I also loved birth. And I left that birth feeling like it had happened to me. And inside of me, I was like, this isn't how it should be. Like, that was my birth, but it wasn't my birth. And so I started really researching and looking into different options. So I go on to have more children. I have 7 now. One is adopted. And the rest of my births, I'm definitely strong-willed. I'll say that. And I've never really been one who is wishy-washy or what have you. So I educated myself a lot, but I also had hospital births because I also appreciated the medical side of it and just having those options. So fast forward, I'm pregnant with baby number 5. I had decided I wanted to be a midwife, but I wanted to start as a labor and delivery nurse. So I went through school. I waddled across the stage, huge, she's 19 now. She's my visual sign of my nursing career. So I waddled across the stage. I ended up sitting for the boards on a Friday, had Lainey on Monday, and I did med surg for a short period and then went right into labor and delivery. That was my dream. And I loved it, but I also was heartbroken over the things that I saw. And I loved your book. I told you when you came on my podcast, I was fangirling. I'm like, oh my gosh, because the things that happen to you happen all the time. And as a labor and delivery nurse, and my students like to say, I'm crunchy with a side of medical, I appreciate an intervention when it's needed. Thank goodness we have them. But I found myself constantly sitting in my car crying and watching women being coerced and bullied and threatened. And I just finally said enough. And I'm like, and that's why I say I'm changing the birth culture one birth at a time, because I can only do so much. But there's a lot of us out there that feel the same way that you and I do. And so that's my story of how I became a labor nurse and then how Labor Nurse Mama was born.
That's an incredible journey. Did your other births turn out better? Did you feel as you had more children, you were able to make choices that were more aligned with your beliefs and values?
I did, for sure. And I definitely picked my providers better after that. Now, my second birth was just super fast. So everything I had planned, but it was perfect because I got there, had him 50 minutes later. So, but I will say that my fourth, he was breech and I agreed to do a version. It was a little bit not as perfect as I wanted because of having to have the version. And then back then they would do the version and then immediately induce you. If I knew what I knew now, I wouldn't have made those choices, but I still had a really empowered birth. And I went into that version, my midwife was willing to deliver him breech. So I felt very much like I was a part of the decisions. With
Like you
the
had
other
options.
Mm-hmm. Yeah.
Yeah.
And looking back, I might not have made the same options I made, knowing what I know now, because the last one I had, he's almost 10. And his birth, I was older. So I had a lot of different things going on, and I ended up being on blood thinners. So the ranges of options varied with each of those kids. But I feel like I made the decisions. I researched and I made the decisions.
You weren't just obediently following direction. Yeah.
Some of my decisions with Grayson were fear-based, looking back, but at the time it was like,
it was still your choice.
Mm-hmm.
Yeah.
Yes. And I knew my midwife would listen to me.
Mm-hmm. And then you're, painting that picture of the nurse crying, on her way home from a long shift. And I feel like a lot of nurses can relate to that. I know I can. What were some of the things that you saw that, horrified you and made you fall apart afterwards?
So the first one was a C-section. When you say horrified me, this was the first one. It was a C-section. First of all, I was very new as a labor and delivery nurse, and this mom really didn't need a C-section. I was still shadowing someone, so I didn't have as much of a voice. And the C-section, I just felt like she wasn't prepared. This is part of why I have a module, a lesson in my birth classes about C-sections. Because what I see a lot of times with C-section is these moms are just taken back without any information. And here's this mom, she's butt naked, sitting up. We're cleaning her, we're doing all these things. Then we're laying her down. The room is bustling. There's different team members coming in, and she's laying there just naked, and no one's talking to her. And I remember, I'm shadowing, I'm learning. So I went up to her, which, it's a sterile field and it's something we have to do. But I was like, why did no one prepare her for that? I was new, so I didn't have C-sections myself. But I made that a mission from then on, that I made sure that at the very least moms know that portion's going to happen. But I really realized they're not looking at her as a person, as a woman who is now sitting butt naked in a room full of people, which is never comfortable, and I know it's not some of the huge problems we have in the hospital, but it was a changing moment.
It was about human dignity.
Right.
Yeah. Being
I'm starting to tear up.
Yeah. So is that something that your hospital did? They removed all the patient's clothes right before the C-section?
So when you get into the room, we have to scrub them. So they have to be naked. Yeah. So they go in, they sit up for their spinal, unless they already have an epidural, we bolus it in the room. And then they get to the operating table and they get stripped down. I mean, you can't, so we have to sterilize them. We have to scrub them. So they're naked while the nurse is scrubbing them, and then we drape them and stuff. But for that period of time, and then we have to put in the Foley, and everybody else is doing their job, which it's their job. And no one's like, oh, she's naked. No one's thinking that. But from the very first, I saw her face and even thought how I would feel to be in that. So that was one of the first real, and I could still see this patient in my brain. That was one of the first moments where I was like, something is not right here.
Yeah. It's making me feel flushed, just thinking about it, I feel warm.
Yeah.
And it's interesting kind of trauma, because it's not what we typically think about of trauma, but like we were saying, it's about a lack of like respecting someone as a human being, treating them more like a piece of meat or some like a task to do.
In all fairness, that part does have to happen. But imagine if she knew that it was going to happen.
Or that somebody was talking her through it. Or helping, you know, if she needed privacy of some kind, helping with that. Or
Yeah. It's a moment during C-sections that I don't think a lot of people are educated on. And that is something, the same thing is I teach my students, if they don't have an epidural, if they're a scheduled C-section or they're converted to a C-section, to ask to walk into the OR, because that in itself makes them feel more human and more powerful,
more empowered, more strong.
Yeah.
Like it's their choice and they're going to their birth instead of.
And most of them have never been a patient before. And, you know, you're not there because you're sick or something bad. So came from one of my VBAC students, which, well, with her VBAC birth, which didn't happen. She ended up a repeat C-section. She walked to the OR and she told me how empowered that made. Instead of being rushed on a stretcher or wheeled in a wheelchair, she walked there like a person, talking to the nurse, her partners at one side. And it was like, she said it just made a huge difference for her.
Yeah. Even like you mentioned, having family in the room, it sounds like in the first one, she didn't have a partner or anybody was allowed back.
Well, and they don't let them back until they know they're numb. Then they do.
So they don't let them in if they're doing a spinal or anything like that.
They don't let them in until they're laid back, draped, and all the sterile drapes are up and the surgeon tests.
Yeah. And I know that's not every hospital, but
most hospitals.
Okay.
Yeah. The majority of the ones, I mean, all of the ones that I worked at throughout my career. I did travel nursing.
I think that was one of the things that really motivated me as well at EBB was the family and friends that were having cesareans were not having empowered, respectful care. Like even if that type of birth was necessary or life-saving, it seems like often they're prioritized last in terms of being given information and support and all those little things that make a difference and make it feel empowering and not traumatizing. So it's interesting that that's like the big, like formative memory you have as a baby nurse.
That was my first.
You know?
Yeah.
Right.
Yeah.
What are some reasons that you've seen that parents might feel hesitant to advocate for themselves when they're there for labor or birth?
So from talking to my students and teaching so many women and talking to them, this is one I did not struggle with, but a lot of them, they want everyone to like them. And they don't want to be that patient. They don't want to be the patient that people are talking about or thinking that they're trouble. And the sad thing is that they really have like this internal feeling that by questioning or wanting something different or having a birth plan, there's some sort of trouble for us. And that has been the thing that has been really eye-opening for me from this side of the labor room, from spending so much time with my moms, because I do like a weekly hangout with my students. So I've gotten to know them very, very, very well. So I think a lot of them are so scared that they're going to be that patient. And a lot of them love their providers. Like they almost idolize them. And they think like I did with my first, that their provider would never do something that's not absolutely best for them. And I do want to say some of my best friends are OBs, and some of the things they do are not like inherently evil, but this is their job. And for all of us, our job becomes sort of routine. So I think a lot of things that are done just because that's how they've always done it. But I think the patients feel like, who am I to question what this doctor who has all this experience, this is what they do every single day. Who am I to question? So I think a huge root of why they don't speak up is, and even when they know that this is not the right choice, they get scared to speak up. And I think it's because they don't want to be disrespectful maybe, and they really want their nurses to like them. You know,
it's a defensive response. I think a reaction we use to cope in terms of something, some people call it fawning as well, like where you just defer to authority. And then there's quite a power imbalance. And then as you were saying, like, even in how you're positioned, there's a power imbalance. You're naked except for a gown, or you're like lying in bed and they're standing over you. And so there's all these like signals in the room to tell you that you're the subject and they're the director.
You're helpless. You're weak and helpless. I just filmed a reel because I teach my students this, but most everyone doesn't realize this. But when you get to the hospital, whether you're being induced or you're in labor or not, you do not have to lay down in that bed. You can stand up and go through your admission questions, do your interview. We can hook you to the monitor. We can listen to the baby while you're standing up. I feel like just that starts the experience off like eye to eye. You know, they're meeting the team, they're standing up, they're not laying down and everyone's coming in over them looking. That's really nerve-wracking, especially if you've never been a patient before. So that, I think, is a little thing you can do. I've had several of my students have never even gotten into the bed at all. Like, they've delivered out of the bed. So I just think we don't think we can do even something, like they can't even say, no, thank you, I don't want to lay down, you know?
Yeah, some people think they have to put on the hospital gown. You know, they have to get in the bed. That's a really good point. And I know anthropologists have written a lot about the hospital bed and how it's kind of this symbol, and it takes up this almost like throne-like location in the room. Like, everything revolves around the bed. Like, you're sick, you get in the bed, you know? So it's there's been research on removing beds from the rooms and only instead having cushions and couches and swings and chairs and balls and tubs and stuff. And it's been interesting to like,
I hope I live long enough to see that.
I know. Yeah. I think there's some research on some Scandinavian countries about it. I know they were carrying out those studies. I haven't seen the final results, but I thought that was a really interesting way to like, let's just remove the bed. I think there were like mattress pads on the floor kind of thing, but no actual hospital bed, which is also incredible to think about how much money hospitals spend on each of those beds. Like, so it makes sense that if you refuse to use it, everybody would be like, why? I mean, how much those beds cost? Like $10,000, $20,000. I know they're really expensive.
They're like transformers. But, you know, I always tell, one of the things I say over and over, I have a couple mantras I say, like you said at the beginning, if you don't know your options, you don't have them. You don't have options if you don't know them. That's simple. But also, is nothing out of convenience or curiosity. And some of my students have said that they've like yelled that out in labor. I'm like, unless it's convenient for you, nothing out of convenience or curiosity, because the bed 9 times out of 10 is convenient for me and the doctors, not for her. It makes it really easy. And I've even confessed to my students, for the first few years as a labor nurse, I could only check your cervix if I were on this side like this, you were laying like this. And I don't know why, but in my brain, that's how I was taught to do it. Okay, mama, let's get in the bed. I'm going to check your cervix. There was no, I mean, I've been a nurse for a long time. There was no like, would you allow me to check your cervix? You know, like none of that. There was, okay, mama, let's get in bed. I'm going to check. Let's see what's going on. And I could not do it unless she was in that position. And then when I started as a travel nurse and I went all over the country, which was really eye-opening, and why I ended up doing what I'm doing now too, because I realized, wow, a mom in Seattle can eat during labor, but in Georgia, she cannot. It's dangerous. Like something's not right. But I had a midwife who delivered anywhere. And I'll be real, the first time I delivered with her, she came in, my patient was like complete, ready to push. She comes in, she gets her out of the bed and takes her to the toilet and sits her on the toilet. And my internal labor nurse system was like, like what, you know, but it was beautiful. And then the rest of the delivery is one of them. I was just crawling around on the floor behind her, putting the pads down when she was ready to push. And that experience taught me that I could check a cervix in a million different, the cervix is still the cervix and it's still the same dilation. But I think a lot of nurses, especially labor and delivery nurses, we're diehard. So a lot of them will work at one hospital for 30 years, like their whole career. So they're not exposed to anything but what they were taught. Then they train the next nurse and then the next nurse, and then they all stay there. They never think outside of the bed, you know? So, and that can change everything.
Wow. Okay, so many quotes from there. They never think outside of the bed instead of outside of the box. That's a good one. In the point about how a lot of nurses and a lot of physicians, they only ever practice in one hospital. And I think that's one benefit of a doula, is because they are at so many different hospitals and birth centers and homes that they've seen things happen so many different ways. And again, like you as a travel nurse, you realize all of the options out there and you don't get stuck in one way of thinking about things.
They don't question policies.
Okay.
And a lot of them don't even know the policies. They're just going on what was told to them when they were trained.
Well,
so
our
a lot of times
is
yes. So a lot of times when I was I'm a question girl. Like I homeschool my kids. I teach them, you ask questions. So I was just having this conversation with my husband. I remember the first hospital I worked at, they checked the blood sugars on every baby. And I was like, why? But I didn't question it because that's what I was taught. So we did it. Well, when I went to my first travel assignment and they checked them on only the babies that needed it, when I came back to my home hospital, I kept asking everyone why. No one really knew why. So I went to the policy and nobody was following the policy. It wasn't the policy. So all these babies were getting their heels pricked because someone probably missed a blood sugar drop. And then everyone was doing this because they were fear-based, so
yeah,
that's an interesting part I saw a lot too.
And another advocacy tip is if somebody says it's hospital policy, you can always say, oh, I'd love to see that hospital policy. Like, yeah, can I have a copy so that I know exactly what the rules are? And then they, can't find it or it doesn't.
That's what I tell my students.
Yeah.
If they quote a study or a policy, ask them to print them. Don't make a decision right then and there unless it's emergency. And then take it home and actually read through it. Because a lot of times the physician is quoting like a little part of the study that benefits them.
Yeah. And it's also a way that doulas and other advocates can get involved. I know in our town, there was a hospital where they kept calling Child Protective Services on parents who refused the eye ointment. So we figured out, like, is there an actual policy? And it turns out there was not. The nurses just believed that they had to do it. They thought it was policy. And then a childbirth educator who's a nurse there advocated to get an actual policy written that explicitly said, like, don't call Child Protective Services just for the eye ointment. And that impacted a lot of people's births because that can be very traumatic and scary. Yeah.
I remember when I first became a labor nurse, they would call Child Protective Services if the mom refuses a bath.
For the baby?
For the baby. Yes.
Wow. Have not heard that one, but it does not surprise me.
Yeah. And I remember at the time we were not educated about the benefits of delayed bathing. That was a long time ago, but I remember being like, what? Yeah. And then we'd have the parents that really needed Child Protective Services, but were following all the rules, so they didn't get called.
Yeah, I'm sure as a labor nurse, you've seen it all.
Yes.
What would you say are some other ways people can get over those mental blocks of, like, just being afraid to speak up? So what we work on with our students, and really that's a lot of our hangouts, is we're diving deeper into how to communicate that to your provider. Because I think when they're taught how to communicate it in a way where they don't feel that they're being rude. And because I think they think it's either, no, I'm not doing that, or okay, and it's not. And so what I teach them is, first of all, you have to know why. I tell them all the time, we don't refuse things just because we can. We need to know, why would that not be appropriate now for me? And if you don't know, be okay with asking a lot of questions and digging deeper and keep going. But I think that for most of them, they have in their head that it's going to be terrible. And what I find is a lot of times it's not as bad as they think it will be, the outcome. A lot of doctors are like, okay, that's fine, or what have you, or they'll state theirs. What I teach them to do is not overcomplicate it for themselves. Like, don't get all worked up and thinking, I have to explain it all and I have to say all these things. And what if I can't remember it all? You can simply just say no. And you don't have to explain yourself. Yeah, that's something I've been learning recently is the more you explain yourself, actually, the weaker and less confident you come across as.
Yes, that's what I tell them. And I actually tell them, speak up and shut up is what I say, because that's how I am. But I tell them, like, zip it, like, say, no, we've educated ourselves and that is not the choice we want to do, but thank you. And then let them fill the silence. Don't you? And it really does empower them. Even if they're really shaky inside, they can stop and take a breath. They don't have to come up with all the reasons why. They don't have to explain themselves. They can say no.
Yeah. Just no, thank you. And yeah, you don't have to explain why you don't want something.
The thing about it is, and I've seen this in practice, the more they try to explain themselves, they give more ammunition for the doctor to break down their defenses. And then the doctor will start breaking down all the things they say. Breaking down a simple no is a lot harder. So,
right. Unless there's a really good reason. They don't necessarily need to know all the private thoughts in your head or you and your partner's private conversations, unless there's an important reason for that. I think sometimes we think we have to explain our no's, and you're right. You don't have to. Like, what about for partners or family members the support people in the room?
So interestingly enough, I just played doula for one of my doulas who had a baby, because I have 2 doulas on my team, and I did not like it at all. I'll tell you that. Number one, I'm used to being kind of like in charge, and it was a really interesting position for me to be in. But your doula really can't refuse things for you. Your partner can, and you can. And I always tell my moms, their job is during labor is to labor. They don't need to have to worry about everyone listening to them. That's when your partner steps up. But your partner has a lot of power, but they have to know everything you know. So we tell our partners, access the courses, do them all, not just our birth coach class. You need to be as educated, because that is one way I've seen a lot of moms broken down. Like, they end up doing what they don't want to do, is because the partner has no idea all that she's learned as to why that's not right for her situation. So when a doctor says things like, well, you don't want a dead baby, do you? Well, no, sir, we don't want a dead baby, of course. But when a partner hears that and they don't have all the education she has, that's really scary. And you don't think that people will say things like that when it's not 100% what's going to happen, but they do. So if they both go in there knowing, like, this is what happens a lot, these are things that are, because I've heard some really terrible things said at bedside that are really absolutely like unbelievable.
Like false, but they're presenting it as truth, or?
Well, just things like that. Like, we've been doing this for a while. You've given it your good gung-ho. I really think we need to go back for a C-section because we don't want a dead baby, do we? And there's like no indication that we're going to happen. Yeah. But, instead of saying, like, giving her all the options. So when things are said, like, I mean, I've heard some really horrible things that are said, when things are said like that, and the partner hears that, they need to be prepared and they need to be educated. Because if she's knows that's not the best situation, and then you've got a partner who's crying, like, babe, like, please go back. Let's do this. We don't want her, like, that's going to be 100 times more when you have a partner who's educated. Like, even my very first VBAC lab student who had a successful VBAC. So I had 10 founding members, the first one to give birth. She's laboring. It's taking longer, which I always prepare them. VBACs are slow. Be patient with your body, because, they don't want to do all the things they do to everyone else, which you don't want anyway. But she was laboring perfectly, but she was not following the rules. And her doctor comes in and says to her, I really think we need to think about going back. Like, I just don't know your body's going to do this, and blah, blah, blah. And of course, she's wide-eyed now because she's in labor. She's unmedicated. And her partner leaned in and said, we're doing this your way. And so he said to the doctor, can you go out? We want to talk. And so the doctor went out. She ended up delivering vaginally like 45 minutes later. But if they hadn't been prepared, and if her partner, maybe she could have refused on her own, but her partner reinforced, like, we know what we're doing. This is the plan and it's safe. Baby's fine. You don't need to rush it. Otherwise, more than likely, they would have been in the OR. She would have been delivered C-section. At the same time, she would have been delivering vaginally if they wait, so.
Right. So the partner, and this is something a doula could do as well, is to help create time and space and privacy so that you can think about it, figure out what questions you're going to ask or what you're going to say. Trish, can I give you a couple scenarios? And you're great at like coming up with these, like what would you say? Yeah. Okay, let's do it. So let's say that one of your students, one of your childbirth education students, has a history of trauma and wants to avoid cervical exams except when she's requesting them. And she's in active labor, comes to the hospital, contractions are like every 2 minutes. Clearly, even though it's her first baby, like this baby is coming. And they say to her, we can't admit you without a cervical exam. What's something she could say?
She can refuse it. Like, she can simply say no. So she needs to know that if she's in active labor, they cannot legally not treat her.
Care. Yeah.
So that one's pretty easy if she's educated. And I would say that anyone's going to refuse a cervical exam, they're usually educated. So that is not true.
But how would you say no? Like, what if they say, but we really need this,
I mean, I would tell my girls to just say, I'm sorry, I'm refusing a cervical exam. You can chart that.
Okay.
And
that seems simple, but it seems so hard. Even for me.
It doesn't have to be. It does not have to be. And I tell my students all this time, I have never once in my career manhandled someone to force them into doing what I want.
That would be extremely rare.
Yes. Sure. And this can go to the point of danger for a patient, because we had a patient one time, she wasn't my patient. She was refusing to push. The baby was right there and having a really deep deceleration. That baby needed to come out. It was a midwife delivery who could not put a suction on, couldn't do a vacuum. So we were waiting for the OB to get in-house to pull the baby out because the mom was refusing to push. And that baby did not have a good outcome. We couldn't make her. We couldn't physically do anything. Now the doctor could have, which he did, put a vacuum on and pull the baby out. That was an extreme situation, but we can't physically force you to do anything. So a lot of times moms think that we have the power to force them to do everything. In a lot of circumstances, we don't. Okay. So you don't have to fight it. Like, that's just how I roll. I tell them, just say no and simple. I also teach my students how to read the room. There's a much different scenario if the entire team runs in and you can tell something emergent is happening and they're like, we need you to roll on your back so we can check on baby. Totally different scenario than if your nurse comes in and says, okay, we're going to have this baby. It's time to get on your back and put your legs in the stirrups and da-da-da. No, you just say, no, thank you. And that's that. So I don't overcomplicate it. They don't have to overcomplicate it. They have a human right to say no to someone putting their fingers inside of you or touching you or forcing you into a position. You have a right. And I think that we don't have that right.
Right. So it's remembering and knowing that you have the right and then being able to say no. And it can be a really simple no. It doesn't have to be a in-depth explanation. I think that's really good advice. I have one more scenario, Trish. This has to do with amniotomy or breaking of the waters. So have you seen this as a labor and delivery nurse when a provider is doing a vaginal exam and they go to break the waters without asking?
Yes. Yeah. And it's frustrating. So this is one thing why my birth classes are a little bit weird compared to other ones, is because I actually teach them all of these things, all of these scenarios, so that they're not surprised. Like when they get GBS testing and they do a vaginal exam in their prenatal without talking to them, that happens a lot too. But yes, I even had a doctor that would break their water during an early induction, like come in the morning, do his rounds, break their water and put an FSE on, fetal scalp electrode. That's what he would break their water with. like 1 centimeter dilated and not say a word, break the water and put an internal monitor
on the baby's head.
Mm-hmm. Yeah.
Yeah. So what advice would you give to families who maybe they just want to have a say, or maybe they know they don't want their waters broken? How can they protect themselves, or how can they speak up? How do you know that might happen?
So there's a huge chance, whether you go in labor or induction, that your provider is going to want to come around and break your water. They make rounds in the morning and they break everyone's water if they deem it's appropriate, which means they're 1 to 2 centimeters, or, the baby's floating and high. They're not going to. But best way to prepare that is, I tell my girls, start having conversations early and often throughout your pregnancy. Talk through these things so that by the time you deliver, your doctors know, I don't want my water broken. I tell my moms, like, if they want to, once they're in active labor, that's fine. It's not really going to shorten their labor that much. Sometimes it does. Sometimes that's the key. Yeah.
And there is evidence it can be helpful with an induction.
Right. That can. But I do teach them to have those conversations. And then for the most part, only agree to it if you want to, once you are actively contracting and your cervix is making change and you're in that. Because for an induction, if we don't break your water and we have a failed induction, they then have the option of going home, unless it's like a major medical reason.
Okay.
So for an elective on the West Coast, they do this more. The East Coast, no. But on the West Coast, if they come in for an induction, especially an elective or a non-emergent type medical one, if it's a failed induction and their water's not broken, they can go home and come back, so that makes a huge difference.
Right. You can stop the induction and you have choices. But what you're saying is once your water's broken, they're not going to say, all right, we can stop inducing you. Mm-hmm. It's kind of like you have to keep going.
And a clock starts.
Yeah. Okay.
They're excited too. I think a lot of women fall into that because, no, they're going to break my water. Like, this is really happening. But if you can delay it, it is best.
Okay. And families can kind of know what the amnio hook looks like, the long kind of like crochet needle kind of thing. But also there's a little finger caught that a lot of people don't realize that a doctor can just put on their glove and you don't.
Well, they can break it with their fingers if they really want to. If the bag is thin enough and, we've got, let's say we have what we call a bulging bag or a tight bag, you can accidentally break that when you're doing a vaginal exam. That has happened to me as a nurse, which we're not allowed. But used to be able to do it in some states, but most states were not allowed to break your water.
It can happen accidentally.
Yeah, it can. But it can also happen intentionally without an amnicot or an amni hook. So I really just say you have to have those conversations. But I'll be honest, I've had students that have told them absolutely they don't want them to break their water, and then they do. In that case, you need to write a letter to the hospital. You need to write a letter to the board. Like,
you could. That's the other thing. I would like you to chart that you just broke my waters without my consent.
Yeah, and then you can ask your nurse to chart that. Yeah. And then, another thing that I feel is really important that a lot of people don't know is that you can fire your doctor and your nurse, and the hospital will have to provide you with a provider and a new nurse. And I know that's really scary to women. And a lot of my students are like, well, then they're going to all really hate me and be mean to me. But honestly, what happens in that scenario is then they get a nurse like me that can deal with the problem child. And I love them, so what will really happen if you fire your nurse is you will get the most patient, best crunchy, labor nurse on the floor.
Who won't bat an eye at your requests.
Right, exactly. And we know the nurses that need to get fired. So we're not going to be judging you on that.
Right. And often when you fire a nurse, they're probably ready to be done with you as well, if you're butting heads.
Well, the flip side, and this is what I tell my students too, is obviously be polite because we are people. And, there have been times I've had to go to work after some really horrible events in my life. So maybe she's just brought that in and it's she doesn't have her head in the game thing. And so what I teach them how to do it in a way that's polite, but hey, I really appreciate you, but we're just not jiving. You're not. Now, if she's really being awful, this is different. But what might happen is this nurse might start crying and you end up giving her another chance and having an amazing experience and bonding for life.
Mm-hmm.
Or she's ready to be done too. And she goes and it's confirmed. Like either way, you need to have the conversation.
And you don't have to fire the nurse directly. You could ask for the charge nurse.
Yes. Yeah.
And then tell them and they could arrange it all.
The thing is it's her experience. It's life-changing for that mom, but for that nurse, she's going to clock out and go home. Now, obviously, there are events that affect us during our work hours, but for the most part, it's another day at work for her. But that is your birth with your baby that only happens
that you'll never forget. Right.
Right. So it is worth having the courage that it'll take a few seconds to speak up and advocate for yourself.
Yeah. And one more thing I think we didn't really say, but with the waters being broken, without your consent, another way, in addition to prenatal visits, is if you're consenting to a cervical exam, to know that might happen and to affirm that you don't want your waters broken if that's what you want.
Yeah. Just having that conversation, speaking it up. I know a lot of people think there's like bad juju or something if you have a birth plan, but a birth plan is just a really easy way to see the things that you desire and for them to have it in, because we put them in your chart. So it's charted that you do not want your water broken.
Yeah.
So, but you still want to speak up and say it.
Right.
And I will speak up and say it.
Okay.
So if you let your nurse know, she knows the doctors that will push that limit. And so what I will do is say, hey, Dr. So-and-so, by the way, she does not want you to break her water. I will advocate for you as well.
Okay.
So
it's good to know. Yeah, it's important to build a trusting relationship with your nurse so that you have a whole team of people there to support you. And obviously, like, this does not happen at every labor or birth, but it's helpful to know that, especially if you don't know the provider taking care of you, like if they rotate call or you're getting somebody that you've never met before, to just know all of these things can happen so that you speak up and prevent them if possible.
Yeah. And just a side note on the cervical exams, if you do agree to an induction, you are going to have cervical exams because we have to titrate medicines. We have to choose which medications to use. So I think a lot of moms miss that. They think, I'm not going to have cervical exams, but you will have to have some if you're being induced.
It should be part of the induction informed consent conversation, but often it isn't, right? No. So when you're choosing an induction, you're choosing kind of like a package of interventions, and you can, some of those you can tweak and decide, or speak up. I want the low dose instead of the high dose, or, and we go into that in our induction pocket guide and other podcasts we've done on induction, but you're right. There's some things that kind of go together, and it's all part of getting true informed consent in advance.
Yeah. But I will say that 90% of my inductions don't even have any idea what medications are going to happen.
Right.
A lot of them come in and they don't. And like, even for my students, we teach them the same, how to navigate the induction. They have choices on the medications, as long as the hospital provides it in stock but they have a choice. Like, she's now one of my doulas, but she started as a student. Her doctor had never done a Foley bulb induction. And Ashley was like, if I'm being induced, she had GDM, she had hypertension, she needed to be induced. She said, if I'm being induced, I want to start with the Foley bulb. And her doctor's like, okay, I haven't done one, but let's do it. Yeah. And that's how it can go sometimes when you speak up to your doctors. They're not all going to fight you about everything. Sometimes that's just what all their patients agreed to, and they've just gotten into the habit. So
like you said, it's not necessarily something devious or manipulative. It's just their work tasks and what they're used to doing. Yeah. Exactly. Well, Trish, thank you so much for coming on the podcast and sharing your wisdom and tips with us. Can you tell our listeners a little bit about the resources you have at Labor Nurse Mama and a little bit more about your podcast?
Yes. So I have a podcast. It's The Birth Experience with Labor Nurse Mama, and you can find me on all of the socials as Labor Nurse Mama. We have birth classes. We have a mama membership that is amazing. It's amazing. And we just have all the things over there, but mostly you find me hanging out on Instagram.
Yeah. And lots of great reels and educational videos on your Instagram. I saw one that you did today about like what it looks like to break the water with an actual plastic bag with the baby inside of it in the water.
It's so funny to have like an old fart like me doing these videos, because like when I started on Instagram, there was no reels. There was IGTV, right? Which was awkward enough. But that reel is so funny to me because I did not expect it. It was so unexpected. I did not expect the gush. And then my dog came running in and was licking the floor. That was funny, but that was a fun reel.
Yeah, very
yes,
realistic.
there's an amni hook. If you want to know what it looks like, there's the culprit.
Right, exactly. So, all right, Trish, thank you so much for joining us and sharing your tips about advocacy. We really appreciate you.
Thank you for having me.
This podcast episode was brought to you by the book Babies Are Not Pizzas, They're Born Not Delivered. Babies Are Not Pizzas is a memoir that tells the story of how I navigated a broken healthcare system and uncovered how I could still receive evidence-based care. In this book, you'll learn about the history of childbirth and midwifery, the evidence on a variety of birth topics, and how we can prevent preventable trauma in childbirth. Babies Are Not Pizzas is available on Amazon as a Kindle, paperback, hardcover, and Audible book. Get your copy today and make sure to email me after you read it to let me know your thoughts.